Okay, so let's start. So we're doing the batch discussion first, and you can see the topic. We're really going to be talking in detail about immunofluorescence. So as you've been introduced to different pathologies in kidney, if you go to the absolute basic of what is really happening and what is damaging this kidney, a large part of it is immune complex mediated, right? And when those immune complexes come in, they are not going to stay silent in the kidney. They induce a lot of inflammation and they bring in a lot of cells with them. And that is how we see the different patterns of glomerular injury. Okay. So let's say these immune complexes came in and they preferentially deposited in the capillary walls. So you will see a lot of endocapillary hypercellularity. You will see a lot of neutrophils there. Everything is a reaction to those immune complexes located in the capillary wall. Now think about it. If those immune complexes came and deposited predominantly in the mesangium, so then what would the pattern of glomerular injury be? It would be mesangial-proliferative. Okay. So when we talk about these diseases, which are immune complex mediated, they tend to produce different types of proliferation. And we look at those proliferative patterns when we look at the kidney biopsy under light microscopy. But we cannot see those immune complexes in most cases. They are too tiny to be seen. Just like that, as you look in the microscope, you will not be able to see the immune complexes. So whatever we talk about on light microscopy is the reaction to immune complexes. So we say diffuse proliferative GN, mesangial-proliferative, membrano-proliferative, okay, and even membranous. Now, there are three ways in which these immune complexes come into the kidney. And one of the most common is when those immune complexes are present in the circulation, okay? So these circulating immune complexes, which are composed of both antigens and antibodies, will come. And the kidney is going to, anything that is in the blood, the kidney is going to get exposed to, right? The kidney is actually gets 25% of the cardiac output. There is constant circulation through the kidney. And if you've got a lot of immune complexes in the circulation, of course, the kidney is going to be exposed to them. And due to various factors, they will accumulate in the kidney, and they may accumulate in a subendothelial location, like you can see here, just under the endothelium, or they may go across and they may accumulate in a subepithelial location as well. Okay. Now, the other, so these are the circulating immune complexes. And the other situation is if you have in situ immune complex formation. Okay. One of the major kidney diseases in which this was described is an anti-GBM nephritis, where we know that there is an antigen, which is the alpha-3 part of the type 4 collagen, which forms the GBM. And against that, antibodies are formed. So those anti-GBM antibodies are working against an in situ antigen, which is a core part of the GBM, and then it goes, and that's where the injury is happening in the GBM as this antigen and antibody reaction takes place. Okay. Now, the third type, which is also going to get discussed today in great detail, is the membranous pattern, because we now know that what we used to call Hayman nephritis, which is the animal model for membranous nephropathy, that is also characterized by in situ antigens, but the location of the antigens is in the porocyte. So all your antibodies against this in situ porocytic antigen result in subepithelial deposits of membranous. So we'll deal with this later. This will come in the second half of today. Okay. So I would like anybody to unmute and tell me, can you give me any example? You've heard a lot of kidney diseases now from this morning. Can you give me an example of this? Image A, an example of a kidney disease which is due to circulating SLE. Very good. Okay. So systemic lupus erythematosus, or more specifically a lupus nephritis, will be mediated by circulating immune complexes, which will go and accumulate in the kidney. Okay. Let's move on. So, and somebody was asking me this as well. quickly go through how we look at our kidney biopsies and our approach, which is how we actually come to the final diagnosis. Okay. So when a kidney biopsy comes into the lab, we don't do this for all our biopsies, but we like to do it for as many as we can. We will do a fresh tissue evaluation. Okay. And what we're looking for is to make sure we have cortical tissue. And we can identify cortical tissue here by these red dots. And you know what these are? These are, of course, glomeruli. Okay. So we can see it in an unfixed, unstained tissue. That's just the core. It's the fresh core which has just come out of the patient's body. And on the other hand, if you see these parallel sort of rays, this is the look of the medulla. Okay. Now, it's very important when we are suspecting glomerular disease that you, of course, you need glomeruli. Okay. Sometimes when the nephrologist or radiologist, whoever is doing the biopsy, if they go too deep into the kidney and you only get medulla, then it's a big problem for us because we don't have the tissue that we need. Okay. Now, if we have the representative tissue, it's not just processed as it is. We either the nephrologist will go in 3 times, give us 3 bits, or the pathologist will divide the tissue that is provided to them, because kidney evaluation does not stop at light microscopy. Okay, it needs immunofluorescence and it needs electron microscopy. And why does it need these 2 things? It's very important that you need the IF and the EM, because like I told you, I can't see immune complexes or the type of immune complexes on LM. I can only see pattern of glomerular injury. So when I want to now decide, are there immune complexes there? If they are, what are the type of immune complexes? Are they capillary wall depositions? Are they mesangial depositions? This is how the IF and the EM will come and becomes absolutely imperative to reach a diagnosis, especially when you're dealing with this immune complex mediated proliferative glomerulonephritis. Okay. So the way we divide it is not so important for you to know. What is important for you to know is we must divide it. If you're looking at kidney pathology, you need to have LM, IF, and EM. You need all 3 modalities. Okay. So after light microscopy, you've seen a lot of light microscopy. Let's talk about the IF, right? So the type of immunofluorescence which is done in kidney is called direct immunofluorescence. Okay. And this is important for you to know. What is direct immunofluorescence? It's basically a technique allowing the visualization of a specific protein or antigen in the tissue section itself by binding a specific antibody, which is chemically conjugated with a fluorescent dye. Okay, so that's how you would define direct immunofluorescence. And this pictorial really tells us what's happening. This is my tissue section, which in case of what we are talking about would be a kidney biopsy. In this kidney biopsy, embedded is the antigen of interest, what I want to detect. Okay. And it's actually an immune complex, right? There'd be an antigen and an antibody which is depositing here in an immune complex mediated disease. And this is what I want to detect. So I will use an anti-human immunoglobulin, right? So I could say that this immunoglobulin could be an anti-IgG, anti-IgA, and that would be labeled with a fluorochrome. So the fluorochrome that is most commonly used is FITC, FITC, which is fluorescein isothiocyanate. And this is what gives it a green color. Okay. So I like asking this question. So what is the antigen here? Does anybody want to try and answer that based on what we've discussed right now? When I have a patient of post-streptococcal glomerulonephritis, am I going to detect, what am I aiming to detect? Am I going to look for the streptococcal antigen? Is that what I'm looking at when I do a DIF? What do you think?
Antibodies or complements.
Yes, absolutely right. Okay. So my antigen, so-called antigen of interest, when I am looking at kidney biopsies and I'm trying to reach a diagnosis, is not what you would truly call an antigen. What I'm actually looking for is the antibody and the complement component of that immune complex. So if I have a post-streptococcal GN that I'm trying to diagnose, I don't go looking for the streptococcal antigen, right? I will look for the immunoglobulin and complement response to that antigen and come to a diagnosis. Okay. So the antigen is in a way actually an antibody or complement component. Now, a lot of people get confused with the indirect immunofluorescence. So I'll clarify it here and we'll talk about it a little later. In indirect immunofluorescence, what you're after is a circulating antibody in the patient's serum. So first and foremost, what you're looking at in a direct immunofluorescence, you're going to put the patient's tissue and you're going to perform a DIF. When you're doing an indirect immunofluorescence, you need the patient's blood sample, you need patient's sera, because what you're looking for is a circulating antibody. Okay. So the way we do it is, for us to detect this circulating antibody, we will create a slide which has the antigen of interest for this antibody. Okay. So let's say the antibody I'm looking to detect is an ANCA, which is anti-neutrophilic cytoplasmic antibody. Then on a slide, I will stick a lot of neutrophils, right? Because that has the antigen of interest. Then I will put the patient's sera in. If the antibody is there, it will go and bind to that slide. And then I'm doing the same thing. I have an antibody, anti-human antibody, which is FITC labeled. Okay. So it's kind of a bit of a sandwich because this is what you want to detect. You will stick it down on a slide with an antigen of interest here. And then you will use an anti-human antibody, which is FITC labeled. Okay. So it's absolutely different. And what are we doing in the kidney? We're doing a direct immunofluorescence. Now, in terms of principle of fluorescence, whether it is direct immunofluorescence or indirect immunofluorescence, okay, the principle of fluorescence remains the same. Basically, if you use a light of a particular wavelength, like you can see here, on compounds which are called fluorochromes, then when they gain energy, they will go up like this, right? And then when they come back to their original location, they will release light of a longer wavelength. Okay. So what FITC does, which is the most common, is that we put blue light on it, right? And if it is there, if it's stuck in that section, then it will get excited. But as it comes back, it will release light in the green wavelength. That is what happens in fluorescence, right? Whether it is direct or indirect. So these are very special compounds called fluorochromes. And this is the property that they possess, which we are using in this investigation. And there are a lot of other fluorochromes as well. I'm just highlighting one or two here, like phycoerythrin or alexafluor. So in phycoerythrin, you put green light is the exciting light and it gives a red color. Similarly with alexafluor. Okay. So it's such an important compound, and this property we're using so extensively in coming to kidney diagnosis. Okay. So now, let's say you got your kidney biopsy. What do we run in the DIF panel? So we run a complete panel on every single case of antibodies against immunoglobulin components, the immunoglobulin heavy chains, the immunoglobulin light chains, as well as complement components. So the heavy chains that we're looking at are IgG, IgA, IgM. Accompanying light chains that we are looking for are kappa and lambda. And then the complement components that we would stain for are C3 and C1q. Okay. Fibrinogen and albumin, they're usually kept as and when required. And albumin is basically used as a kind of a technical control and also gives you a background. So in immunofluorescence, there is sometimes a background. So we use albumin just to check whether what we are seeing in the other stains is just background. If it's equal to albumin, it needs to be beyond albumin to be considered a good positive. Okay. So can somebody tell me which pathway of complement are we looking at when we are detecting C1q? Classical pathway, right. So Abhinav is absolutely right. When we put in a C1q, we are checking for classical pathway activation, and C3 is of course common to all pathways of complement activation. Okay. So this is how we would do it. we would stain for everything on every case, and then we would look for patterns and come to a diagnosis. Okay. So when we look at the IF and you've seen some images, we basically have to grade it. We have to localize it. Where is it positive? And we have to determine its nature. So there are three ways in which we look at immunofluorescence. Now, this is, of course, a semi-quantitative technique. We are not able to tell itna immune complex hai na? We don't give it a number. We just semi-quantitate on the tissue, and the usual scales are 0 to 3 plus or 0 to 4 plus. Now, in terms of location, as we look at the whole core, we can determine whether the staining looks focal or diffuse. And in kidney pathology, like Dr. Adarsh told you in the morning, diffuse means more than 50% of glomeruli or most glomeruli, whereas focal means less than 50% of glomeruli or few glomeruli. Okay, so we would see whether the staining is focal or diffuse. Then in the glomeruli, is it segmental or global? Okay, these are terms which you will hear again and again in kidney pathology. So again, global means nearly the whole glomerulus, individual glomerulus. Segmental means part of the glomerulus. Okay, and then we would want to know whether in that glomerulus the deposits are capillary wall in location or mesangial in location. And we must also keep a lookout for extraglomerular deposits. Are there any deposits in the vessels? Are there any deposits in the tubules? Now, in terms of nature, we are looking for linear or granular. Okay, so let's start looking at some images. Before that, so I've picked this out from Robbins because this is that table that you will all be looking at, I think, repeatedly, as you just want a little synopsis of the different pathologies in glomerular diseases specifically. So I'm hoping that by the end of this batch discussion, we need this particular column to be absolutely clear on what they're talking about, and we'll really simplify. We want to simplify this for you now. Okay. So we're going to start with the first one. You've seen post-infectious glomerulonephritis in a lot of detail today, this morning, right? If I just take you through this row for this disease, because you've heard about it so much, most frequent clinical presentation is nephritic syndrome. It's definitely immune complex mediated, something to do with streptococcal antigens and its antibody response. We know on light microscopy that it looks diffuse proliferative, and that includes endocapillary, mesangial, and leukocytic infiltration. And then the IF, which was shown to you, there are three patterns of IF. You've got garland, you've got lumpy bumpy, and starry sky. And you'll see the presence of IgG and C3. Okay. When they say granular IgA, in some cases, they are referring to the other organisms which are not streptococcal. Does anybody remember which organism induces more of IgA within the post-infectious GN? Staph. Yes, thank you, Dia. So when you have a staph-associated infection related GN, those are the cases where you get more IgA. Okay. And on EM, of course, you're going to see presence of subepithelial humps, and subepithelial humps are really the deposits which have escaped all the leukocytes. There's so many leukocytes there. Of course, it must have started as subendothelial deposits, but the leukocytes came in to eat them up, or they're all gone, and whatever could escape onto the subepithelial side is now going to leave a footprint of that disease, and those are the subepithelial humps. Okay. And this is, again, an image that you've seen in some detail in the morning. Okay, so I have to tell you which antibody stain this is, because they're all going to look the same. Sub green dikhenge, hai na? They're all FITCI labeled antibodies at the end of the day. So I am telling you that on this particular IF slide, so what we would do is we'll get fresh tissue for immunofluorescence. That's another point which I have forgotten to mention. Like for light microscopy, it's formalin fixed tissue, just like the rest of pathology. But for immunofluorescence, we get fresh tissue. We freeze that tissue and cut thin sections from that frozen tissue on a special machine called a cryostat. Okay, and then we'll set up 7 slides and we'll put FITCI IgA, FITCI IgG, FITCI IgM, FITCI C3, FITCI C1q, FITCI kappa, FITCI lambda. That's how you'll get 7 slides. That's your immunofluorescence panel. Okay. So I'm showing you the relevant antibody. So I have a FITC IgG, and I can see this glomerulus, and you can see very nice, predominantly capillary wall, coarse, granular, lumpy, bumpy. And if I had to semi-quantitate this, I'd say good 3+. I could also call this Garland pattern over here, and this would be consistent with a post-streptococcal glomerulonephritis. Okay, so I think I only have the IgG, a very good IgG. But of course, would it only be IgG on the panel? No. When I look at my whole panel, I will see, yes, I also have C3 there, right? Because there's definite complement activation happening in a PSGN, and I will see those deposits. I will also have kappa and lambda, because heavy chains are not going to come alone, right? The IgG will be IgG kappa and IgG lambda. So that's how my panel would look. Okay. So whenever you look at your textbooks, it's telling you the most important antibody there. Yes.
Ma'am,
any question?
How did we come to the conclusion that capillary wall has the antigen deposits?
Okay. So why do I think that this is capillary wall staining? So like I was saying, so unlike I'm making out that this is a glomerulus. Can you make out it's a glomerulus?
Yes, ma'am.
Okay. So you make out, sometimes it's very difficult actually. On a practical basis, if it's not a good thin cut cryostat section, it's a pain to figure out glomeruli. What we look for is this appearance of a Bowman's capsule. Okay. Now within this glomerulus, I can make out that the deposition is mostly at the periphery. If you can see my arrow there. Okay. And now I know what my glomerulus should be looking like. So I will assume that this is my mesangium, right? Because the mesangium is the stalk which is in the middle. And from there, the loops come out like this, like this, like this, right? So I can see that all my staining is at this periphery, and it appears to be along the loops. And wherever I would expect my mesangium to be, which should be here, I should have some mesangium here. I can see it. If I look carefully, I think I can see that this is the mesangium and it is negative. Okay. Of course, you can have deposits in both locations, but the look, I think that's a very good question. The look of capillary wall is this. It's at the periphery, and you know how your glomeruli look, and this is where your capillary loops are. Okay? Does that answer your question?
Yes, ma'am. Thank you, ma'am.
Okay. So we'll move on. Now I'm showing you again, it's a FITC IgG. I'm telling you it's a FITC IgG. But now can you see how different it's looking? Very different. Let's go back and see. Coarse, granular. And you look here, and it looks very different, right? And again, this has been shown to you in the morning. This is now, again, capillary wall. I would say this is capillary wall. I can see the loops. It's a bit of a folded glomerulus, if you can imagine that. But instead of granular, it is linear. It is paint, brush, stroke, and strong, 3+. Okay, so this is the look of which disease? Can anybody tell me?
Good question.
Good question. Correct. So an anti-GBM nephritis will look like this. So you're never going to forget this once you've seen it. Hai na? Anti-GBM nephritis has linear capillary wall IgG. It's also called paint, brush, stroke. And of course, G akele nahi aayega. It will come along with some C can have, and it will be kappa and lambda. Kappa and lambda will also come. Okay. Let's move on. Again, I have a FITC IgG, right? I now have a FITC IgG, and I will talk about this one because I don't think we've talked to you about this disease yet. But this is, again, capillary wall. I think there's no confusion there. It's more capillary wall. If you look very closely, if you can zoom in into your screens, you'll see that it's fine granular. It is still granular, but it's a different texture of granular. It's fine granular and nearly pseudo-linear. You know, if you just took a quick glance, you'd say it's linear, but it's not. It's got some granularity to it. Okay. So when you get IgG in this carpeting fashion, which is granular, global, looking equal, everywhere the G is looking equal, which is very different from the G that you saw in the post-streptococcal G, and very different looking. This is also granular, very irregularly placed. That is post-streptococcal, right? This is from a patient of membranous nephropathy. Okay, so that's another condition where you'll get a lot of IgG, and if you look at your table, you'll see it there. There is also IgG. It is also granular, right? But it's a more regularly placed granular, right? Can somebody tell me what the EM of this patient would be? Do you know? PGs would know. Dia? No? Okay. So
Subendothelial deposits.
Subendothelial.
Survi?
Yes.
Sub what?
Subendothelial deposits.
Subendothelial. Oh. Dia?
Ma'am, we will find subepithelial electron dense deposits.
Yes. Okay. So in a membranous, you're going to get regularly placed subepithelial electron dense deposits. Okay. So for the undergrads, when you see your table, you will see both PSGN and membranous will say IgG and C3. Okay. दोनों में IgG C3 होगा. When you look at the EM, दोनों में subepithelial लिखा होगा. But they are so different, right? Because in the post-infectious GN, you're going to get coarse, granular, irregularly placed IgG. When you go into the EM, there'll be irregularly placed subepithelial humps, right? Large, ek hoga, then there'll be nothing for a long time on the loop. Whereas in membranous, everything will get regularly placed, and Dr. Adarsh will go into details on this in your case study. Okay, so easy to remember now all the important conditions which have IgG in them, right? So this is just, I wanted to bring this out, and this is how we read the panels. This is how panels look like. So I'm going to read this panel for you. I have a negative IgA, right? I have a 3+ granular capillary wall IgG. I have a negative IgM. I have a similar looking C3 to the IgG, right? Kappa and lambda are also ditto, right? C1q maybe traces to 1+. So this is how we would read a panel. And then we would look at a light microscopy and we'd come to a diagnosis. This is a patient of membranous nephropathy. You have the presence of IgG C3 along with the accompanying light chains for the IgG, which is kappa and lambda. And again, primary versus secondary, Dr. Adarsh will talk to you about later. Okay, but this is just to give you a feel of what that actual in practice, how we deal with immunofluorescence. So let's move away from IgG. You've seen a lot of IgG containing glomerular diseases. This is now FITC IgA. Now, can you see how different it is? This deposit is predominantly mesangial. Okay, when we had capillary, यहाँ इसके capillary walls होंगे. You can't see them in this particular image. If we alter the brightness, we might be able to see them. तो वो background में negative होंगे. Okay, so these would be the capillary loops where my arrows are going, and there's nothing depositing there. But what you can see is a 3+ granular mesangial deposition for IgA, and this would of course be classical for an IgA nephropathy. But let's look at what a panel looks like. Okay, so it's not only going to be IgA. With the IgA, it usually comes with some amount of C3, might be dimmer or might be equal. So it's dominant or codominant IgA is how we define IgA nephropathy. And you will see accompanying light chains, and there might be some lambda accentuation, which is normal in IgA nephropathy. Okay, but you can see G is negative, right? Negative IgG, negative IgM, and negative C1q. So this is how you would get to the diagnosis. So here I would say, okay, in the correct, I would of course need my light microscopy. I've seen my light, I come to the IF, I see this IF, I say this patient has IgA nephropathy. It's defined as dominant or codominant deposits of IgA. And you must remember that there is a systemic form of IgA nephropathy. Maybe we will touch upon it on the systemic disease lecture also. It's called Henoch-Schönlein purpura, right? And has anybody heard of HSP? Henoch-Schönlein purpura. Can you tell me what are the features of HSP? No?
Ma'am, arthralgia or joint pain.
Very good. And arthralgia, joint pain. हो गई.
और मैम याद नहीं आ रहा.
Okay, so it's usually a spectrum of joint pain, abdominal pain,
Ma'am, purpura
okay?
and renal disease. मतलब hematuria.
Yes. So 4 चीजें होंगी in an HSP. Patients will have arthralgia, abdominal pain, palpable purpuras, and then they'll have kidney involvement. And it's basically a form of small vessel vasculitis. So because that vascular disease vessels get IgA deposits there, so they will go and cause ischemia. So you'll get joint pain, you'll get abdominal pain because of that. Okay? And of course, palpable purpura. Okay. So in that case also the kidney biopsy may show you IgA. Now let's look at another panel. This panel is very easy to interpret. Anna? Let's get an undergrad in. It's a very easy panel. Who can I call? Ravi. Ravi, would you like to unmute? No? Nishant? Okay, last try. We'll try Aryaman. Aryaman, would you like to unmute? It's not so difficult, is it? Okay, volunteers. Otherwise, we'll move on. Anybody would like?
Streptococcal.
Abin, Hanji, bolo. Tell me.
Post-streptococcal glomerulonephritis.
Okay, why do you say post-streptococcal?
It's C3. All others look quite negative.
Okay, so what phase of streptococcal will now show no IgG and only C3?
I don't know, ma'am. I don't know.
Okay, so I think we kind of can take that answer, but the lack of IgG is a little worrisome, right? All the post-streptococcal we've shown you till now have some IgG there, and we've shown you the pattern of IgG. Okay, so post-streptococcal GNs, you should get G, you should get C3. As they start resolving, then you may have only some leftover C3. Some post-streptococcal GNs may have only C3, but if they have only C3, we get worried. Okay, we get worried because we know that there is a condition called C3 glomerulopathy, which initially used to be called type 2 MPGN, right? So the MPGN category, which is complement only, looks like this. I think this was somebody was asking me. If you have an MPGN on morphology, let's say this patient had an MPGN on morphology and I saw this immunofluorescence panel. And on this immunofluorescence panel, what can you see? It's pure C3. There are no immunoglobulins, A negative, G negative, M is traced to 1+, nothing in comparison to the C3. There are no light chains there. That's a good hint towards there being no immunoglobulins, because if immunoglobulin aayenge, light chains aane chahiye. There's also no C1q. So you have a pure C3. And this is the situation where you must think of a C3 glomerulopathy, okay, which was originally called a type 2 MPGN. So the interpretation on this panel would be that there's a pure C3 on immunofluorescence. Okay? And like Dr. Adarsh told you, the continuum. So this patient could maybe have a DPGN on histology, could be an MPGN on histology. It depends on what stage you're biopsying the patient at. Okay. Now, one situation or one kidney disease where you're going to get not only glomerular deposits, you can also get tubular basement membrane deposits, and you can also get vascular deposits. Let me see if I can find a convincing vessel. I think that is a vessel. Okay, this is also a vessel. So when you get glomerular as well as extraglomerular deposits, and if you get full house deposits. So what does full house mean? Full house means that whatever panel we're doing, all 7 will be positive, right? You have seen panels of DIF till now where something was positive, something was negative. And based on the pattern of what is positive, what is negative, we are coming to diagnosis. When you're going to see patients of lupus nephritis, especially the full-blown class 4 lupus nephritis, then what you will see is full house. A, G, M, C3, C1q, kappa, lambda. Everything will be positive. And not only will it be positive in the glomeruli, it will also be positive in the tubules. You'll see tubular based on membrane granular deposits as well as vascular deposits. Okay, so this is an image from a FITC C1q stain, and you can see that there are deposits everywhere. Okay, so this image is a nice image to keep in your head of what lupus nephritis can look like. Now, I'm going to touch upon a little more advanced topic here just to complete the spectrum of when we talk about DIF. And I think this is touched upon to some extent in your undergrad text also. Okay, so what this is monoclonal paraprotein related disease. So when we look at immunofluorescence, till now, everything that we've seen is polyclonal. Okay, what do I mean by polyclonal? I mean that if I have an immunoglobulin, it is coming with both kappa and lambda light chains. That is what is the meaning of polyclonal, which means that the plasma cells that are producing these immunoglobulins, they are not malignant or neoplastic plasma cells. They're usual plasma cells which would proliferate when they're producing antibodies. And those plasma cells will be producing IgG kappa and IgG lambda. They will be producing IgA kappa and IgA lambda. Correct? That is the meaning of polyclonal. Now, sometimes plasma cells produce only one light chain or maybe only a heavy chain. Okay? They are now neoplastic plasma cells. And when they release such things into the circulation and they deposit in the kidney, we can diagnose it because we have immunofluorescence, right? I can tell you whether the deposits in the kidney are polyclonal or whether the deposits are monoclonal very easily in kidney because I can run a direct immunofluorescence. So let's look at some examples. This is a very common disease which will affect the kidney. This is a, let's say, 70-year-old patient who presents with, let's see, maybe bone fractures. And you look at their kidney biopsy and you see some smudgy eosinophilic material. And you run an immunofluorescence and you see that this material, which is in the glomeruli, so you can make out the glomerulus. This material in the glomeruli stains only for lambda. It doesn't stain for kappa. Okay? And I can also see the material in the vessel wall. Can anybody guess what's the diagnosis?
Multiple myeloma.
Okay, I think we'll take that. So this patient has a myeloma which has produced what in the kidney? Kidney में क्या deposit हुआ? The product of that plasma cell. What is it? You've learned this in general part also.
Benz-Jones protein.
No, Bench-Jones protein is okay. They're light chains. They come out into the urine from circulation. Anybody else? Amyloid. Yes, thank you, Surbi. General path में पढ़ाते हैं हम. I don't think I'm out of syllabus yet. We talked to you about amyloidosis in third semester. So, amyloid. Okay. So, I just want to give a disclaimer here. Most patients of AL amyloidosis do not have an underlying myeloma. Okay. They have much smaller clones, not full-blown myeloma. Okay. But we'll take that because I gave you a very suggestive history with bone fractures. What I was trying to get at is AL amyloidosis. Okay. So, AL amyloidosis is what we call light chain amyloidosis. It is a type of systemic amyloidosis, and we teach you this. You have AL amyloidosis, you have AA amyloidosis. So how do we diagnose that it is A light chain amyloid? We do a DIF on the kidney and we prove that this amyloid is restricted. Ya kappa only hoga, ya lambda only hoga. That means it's come from a monoclonal plasma cell proliferation. Okay, so this amyloid is AL amyloid, lambda restricted. Now, another example of monoclonal related disease is in this panel, which is looking very interesting, isn't it? It's a very interesting panel because in this patient's kidney, I can see that there is only IgG depositing and nothing else. Absolutely nothing else. With the IgG, there is no kappa lambda also. Isn't that strange? It's very strange. Because with IgG, up till now, whatever I've talked to you about, when there is IgG, it's going to come with its kappa and its lambda. So this is a hint for us that there is something very different and very wrong with this kidney because it's only deposition of IgG. And this is another group of diseases which are driven by monoclonal paraprotein, and they are called MIDD, monoclonal immunoglobulin deposition disease. And MIDDs could be only light chain. So you could have a light chain lambda MIDD, light chain kappa MIDD, or it could be a heavy chain MIDD. So this patient had an IgG. Okay. So you don't need to know the details of this. If you know that these are entities which also affect the kidney, that's great. Now we need to talk about, you have to complete the spectrum. Not everything is immune complex mediated in the kidney, right? You're going to hear about a lot of diseases in the kidney which have no significant immune complex deposition and would therefore appear to be IF negative. So let's look at what are these diseases. Top of the list is minimal change disease and FSGS. Okay. So again, we'll talk to you about this in a seminar. But MCD FSGS is the prototypic example of a non-immune complex mediated glomerular disease. Here, the pathogenesis is direct podocyte injury. You've seen podocytes multiple times already. When there is a direct podocyte injury, it just flattens those podocytes and causes heavy proteinuria. We will see changes, no changes on light microscopy in MCD. I will show you what FSGS looks like in the seminar. But when we run an IF, I just wanted to show you here to complete the spectrum, it will show no significant deposits. Okay. Now, what does that mean? That means you're not getting any IgG there. You're not getting any IgA there. But even your textbook, if you read that column, if you go to MCD FSGS, it says IgM positive. Okay. I think it says C3 positive also. So here I would like to just clarify that these are non-specific entrapments which happen in these proteinuric patients. So IgM is the largest immunoglobulin, and it goes and it just gets stuck in the glomeruli. So that is why your text also states that there is IgM positivity. It's non-specific entrapment. And especially as there is sclerosis, like in an FSGS or even in globally sclerosed glomeruli, they non-specifically entrap a lot of things. Specifically, IgM, they can entrap, C3 gets entrapped, and sometimes even C1q. So when we interpret IF, and especially for our PGs, we will always tell them, be very careful in your interpretation. You need to know what is real, what corresponds to real immune complexes, which will correspond to ETTs on EM, and what is just non-specific entrapment. So one group of diseases which is not immune complex mediated, MCD FSGS, know that it can non-specifically entrap. The next non-immune complex mediated disease is diabetic nephropathy. Okay. However, on IF, it can show some staining. So I would like to clarify here, what is that staining? You can see glomerular capillary wall as well as TBM staining for IgG, uske saath sometimes kappa and lambda also. And it's not granular, it looks linear, but it's actually just a linear accentuation, right? So in the kidney, we'd ask you, when do you see linear staining? Anti-GBM nephritis is number one. And in diabetic nephropathy, you can get a linear accentuation of IgG. And the clincher between these two entities is, in diabetic nephropathy, it will also be seen in the tubular basement membranes. Okay? And when we talk about diabetes, we will, I think we will show you histology. It will be more clear. But here I just want to tell you that this accentuation is just because of some non-specific interactions between IgG and all these products which deposit in diabetes, all the advanced glycation end products. There are some charge-to-charge interactions and things like that. So it's not specific at all. Okay? So again, when you read, you'll see that it says IgG linear. but you need to know what we mean here. Now, another thing which is negative, which we also discussed last, was ANCA-GN. So ANCA-GN is a type of crescentic glomerulonephritis. It is posse-immune, which means when you do your regular panel, it'll all come negative. You won't get anything very significant. But if you ran a fibrinogen, this is a very nice image. You can see the fibrin-rich crescents. You can even make out this is the crescent, this would be the underlying tuft. Okay. So we don't run fibrinogen routinely, but if we want to highlight a crescent, it's a great way to highlight them. So coming back to this table, I hope now that when you go back and you look at this column, at least, it should be absolutely clear what is really happening. Okay. So you'll see FSGS, focal, M and C3 in many cases. So there's no confusion here. This is still not an immune complex mediated disease. It is just non-specific entrapment. Okay. Right. Any doubts here before I move on? Okay. So now we are going to talk a little bit about indirect immunofluorescence. I've already talked to you about the difference of what we are doing when we run an indirect immunofluorescence versus direct. We are looking for antibodies in the patient's sera, and for that, we are putting the antigen of interest, sticking it on the slide. Okay. Now, the two very important antibodies that you must know about, which we are detecting by indirect immunofluorescence, are anti-nuclear antibodies and anti-neutrophilic cytoplasmic antibodies. Okay, so that's the ANA and the ANCA. So what do we need to know about ANA? ANA, when it is done as an indirect immunofluorescence, we use a HEP2 cell line, which is an epithelioma cell line, if I'm not wrong. I think it's a squamous cell carcinoma derived cell line. I don't know if Adarsh is around here. And so basically, what do we need as the antigen? Surbhi, what are you saying?
Laryngeal cancer cell lines.
Laryngeal cancer. So it's a squamous cell derived, am I right? Must
Yes,
be.
ma'am.
So when we, so what do we need? If I want to detect anti-nuclear antigen, I just need a nice clean layer of cells which have nuclei. So these cell lines have now been standardized for this investigation. And when we run the IIF, we will see presence or absence of nuclear staining. But not only that, we will also see the patterns. Okay. So it's a good thing if you know some of these patterns. We have a centromeric pattern, like you can see here, multiple small dots, versus a nucleolar pattern, which is more large, confluent, smaller numbers. Then you have a homogeneous sort of pattern, a peripheral pattern, and a speckled pattern. Okay. So what is the importance of knowing these patterns is that they correspond to different types of antigens within the overall, if I talk about different types of antibodies within the overall ANA. Okay. So I can say ANA positive, I can give a pattern. And when we talk about this pattern, this corresponds to certain specific antigens. And the different types of antigens correspond to different autoimmune conditions. Okay. So maybe the important ones for you to remember are, for example, the dsDNA. We consider dsDNA as a very specific antibody within the SLE diagnosis. So what kind of ANA pattern does it show? It shows homogeneous. Then if you look at the Smith can show peripheral rim. It can also show speckled. Okay. But ANA is a very important antibody which is detected by IIF. Now, the second important antibody is the ANCA. Okay. So what we need to know about ANCA is we take a slide and we have a nice thin layer of spread out neutrophils, because that is the antigen that we're going to use to capture those antibodies onto the slide. And we will then stain and we will look at their pattern. So it is called cytoplasmic anchor. If you see a cytoplasmic pattern with interlobular accentuation, as you can see here. So you can see it's cytoplasmic, it looks quite granular, but then you see this interlobular accentuation. Now you can call it an atypical C anchor if it looks cytoplasmic, but it doesn't show interlobular accentuation. Okay, so these are just pattern-based diagnoses that are given. On the other hand, the perinuclear anchor, which is the P anchor, tends to just appear perinuclear with, again, this sort of internuclear accentuation, as you can see here. So that's the P anchor. So you can only really see the nuclei, right? Atypical anchor is a combination of C and P anchor. And atypical anchors tend to come in a different sort of disease group. So let's just talk about things which affect the kidney right now. Now, this cytoplasmic anchor is directed against proteinase 3. That's the major neutrophilic cytoplasmic antigen against which it is detected. That's the proteinase 3. The P anchor is directed against myeloperoxidase. Okay, so this is important for you to remember. You need to remember the main antigen against which this anchor is directed. And in terms of clinical conditions, the C anchor most strongly correlates with this condition, which is called vaginous granulomatosis or granulomatosis with polyangiitis, which is a new terminology, GPA. And the P anchor correlates with another type of vasculitis, small vessel vasculitis, which is called microscopic polyangiitis or MPA. Okay, so but when we do a kidney biopsy, these anchor-mediated glomerulonephritis look pretty similar to us, right? They will form type 3 crescentic type of morphology. The other interesting thing to remember is if somebody asks you about the fixation of these neutrophils, it's important to remember that this P anchor pattern is actually an artifact of ethanol fixation. Okay, so if I were to fix these neutrophils with formalin, formalin is also a very standard fixator, but if I fix these neutrophils with formalin, then I wouldn't get the P anchor pattern at all. Okay, it would all look cytoplasmic because the P anchor antigen is also actually present in the cytoplasm and it would get fixed there by the formalin. So you really need an ethanol fixation for it to all go and stick to the nuclei. Okay, so I hope that there's a bit of a anchor is an important discussion point always for undergrads, also for postgrads also. So this is absolute basic of what you need to know on anchor. Okay, so let's move on now. I would like if Anjana is there to, I can't see participants. Can somebody talk us through this case?
Albin, please unmute yourself. And
Hello, am I audible?
yes, you are audible. You can just read the case.
A 10-year-old male presented with history of fever and cough, which was treated at a local hospital. 2 weeks later, he noticed dark-colored urine and facial puffiness. On investigation at AIIMS, blood pressure of 140 by 100 millimeter mercury, serum creatinine 1.5 milligram per deciliter, 24-hour urine protein 2 grams, serum C3 low, serum C4 normal, urine microscopy, 40 to 50 RBCs, dysmorphism positive, RBC cast positive, anti-streptolysin titers high, ANA ANCA negative.
So what are your thoughts? What are you thinking when you read this? What do you think the patient has?
Post-streptococcal glomerulonephritis.
Okay. Yeah, so this is a very classical picture of a post-streptococcal glomerulonephritis. Okay. So why do you think there's a 2-week gap between the first symptom?
antibody formation against the antigens in the streptococcal.
Yes, it takes time. So that's why it was initially called the classic post-streptococcal glomerulonephritis was called post-infectious because there was this usual time gap in appearance of symptoms. Okay, so I'm going to take you through the investigations again. So this child is hypertensive, has a high blood pressure, has renal dysfunction. Although I haven't said oliguria, but there is definitely some azotemia, right? There is urinary protein of 2 grams. And if you remember my when we first spoke in the case study, the usual protein coming out in 24 hours is only, does anybody remember?
150 milligram.
50
One-
milli.
Yes,
Less than
only
150
one.
milligram.
So it's 2 grams, which is significant, but it's not nephrotic. Nephrotic, how much protein needs to come out in 24 hours?
Greater than 3.5.
Greater than 2.5 grams. So you've got a subnephrotic proteinuria. So I have hypertension, azotemia, I have subnephrotic proteinuria, and I have significant hematuria with active sediments, very glomerular looking sediment. Yes? Along with that, I have evidence of complement consumption in this serum. I have a low serum C3 and a normal C4. And I have a very strong evidence of streptococcus there because the ASLO titers are high. Okay, so you're absolutely right. We are most likely dealing with a diagnosis of PSGN. So, the clinical syndrome is it A, nephrotic, B, nephritic, C, isolated hematuria, D, chronic kidney disease? Who would like to answer? Is it too easy now?
Nephritic.
Nephritic syndrome, right? So this is very clear that this patient has a clinical syndrome which is consistent with nephritic. It's too easy, I think. Okay, next question. The expected direct immunofluorescence is A, IgG linear capillary wall, B, IgG linear accentuation capillary wall, C, IgG C3 granular capillary wall, D, negative standard immunofluorescence.
C.
D, correct. G and C3 granular capillary wall. Brilliant. Okay, next case. Who will talk us through this case? Anjana? I cannot see participants. I don't know what I've done.
Anmol Gupta, please read the next case.
Yes, ma'am.
Just read through the case.
A 50-year-old male presented with facial puffiness and reduction in output. He gave history of repeated hemoptysis. On investigating at AIIMS, blood pressure 140 by 100 mmHg, serum creatinine 8 milligram per deciliter, 24-hour urine protein 2 grams, serum C3 normal, serum C4 normal, and urine microscopy 100 RBCs, dysmorphism present, RBC cars present, ANN negative.
Do you have any thoughts? You want to say something about what you think?
Good pastures.
Good pastures. Okay, so let's understand. So why did you say good pastures? You're probably right, but
Why can't
Because of the history of hemoptysis.
yes.
And
Good.
we can also suspect various kinds of vasculitis with a history of hemoptysis and hematuria, though like normal C3 levels would not be found in good pastures. I'm not sure. Good pastures should involve some kind of complement being deposited in the glomerulus, right?
It might not have very low, but yeah, slightly reduced actually. Yes, you're right.
Though
I think
hypertension as a anemia do suggest a nephritic kind of condition, but like looking at the clinical history of hemoptysis and hematuria, one can also suspect vasculitis.
Yes, Exactly. So I think you've gotten it. There are only two differentials. If I read that history, I will think of only two things, and you have mentioned them both. Okay. So this is classic appearance of a pulmonary renal syndrome. है ना? Lung be involved hai, kidney be involved hai, based on this clinical history. So if we think of conditions, and the kidney is involved in a very nephritic sort of way. So again, we'll go through why we think it's nephritic. There is hypertension, there is severe azotemia, there is mild proteinuria or subnephrotic proteinuria, and there is significant hematuria. So it's the same syndrome. It's nephritic syndrome again. Plus there is lung involvement. So put those two together and you think good pastures. That's number one, or one of the differentials. And the second differentials I would have is a small vessel vasculitis, by which I mean an ANCA. Okay, bilkul. So when it is ANCA, it could be C ANCA or it could be P ANCA. And what is C ANCA related disease called?
Vaginal.
Vaginal.
And that's a classic pulmonary renal syndrome. You see a lot of lung films of what vaginus looks like, and there are nodules and things like that. Okay, so these are classic features, and these are the two differential diagnoses. Okay, so if we got this patient, we would have the absolute differential diagnosis, and I haven't given you one.
Facial puffiness related to a sinusitis that also happens in a Wagner's facial puffiness.
No, if I said nasal congestion and something like that, you may attribute it to vaginus. But in this kind of context, if somebody says facial puffiness, it is because of the mild the proteinuria. Okay, so there is proteinuria there, so there would be some hypoalbuminemia and edema. And you know that facial puffiness is one of those classical features of a kidney proteinuric disease patients, right? You can get pedal edema and you can get facial puffiness. Yes? And then, of course, that can progress to anasarca.
Right.
Okay? But yes, I mean, you must think of all of these things when you get such clinical scenarios. So let's move on. There are some questions there, and then we'll discuss it. So question 1, identify the investigation and the pattern. Who would like to attempt? Anjana.
That's the C ANCA.
Okay, what's the investigation that you're seeing?
That's the immunofluorescence, and it has detected a C ANCA.
Is it direct or indirect immunofluorescence?
Indirect, I guess.
Okay, yes. No, it is definitely indirect. Okay, direct immunofluorescence is what you see when you see kidney tissue. That is direct immunofluorescence. So this is indirect immunofluorescence. You are correct. This patient's sera has been put on a slide which has neutrophils on it, and this patient has ANCA, and you're absolutely right. It is C ANCA. Is it typical C ANCA or atypical C ANCA? Can you describe it? Is it typical C ANCA type pattern? Okay,
Yes,
I'll
seems
answer.
like typical.
Yes, it seems typical, right? So you can see granular cytoplasmic along with this interlobular accentuation or internuclear accentuation. Yes? So this is classical C ANCA. So it's cytoplasmic and there is an accentuation between the neutrophilic lobules, nuclear lobules. Now you have an additional investigation which is positive. Now on this patient's kidney biopsy, if you ran a DIF, what would it show? A, IG, same options as the last. G, linear capillary wall, G, linear accentuation capillary wall, G and C3 granular capillary wall, negative standard immunofluorescence.
Negative standard immunofluorescence.
Correct. Absolutely right. Okay, this is a patient who has an ANCA-mediated glomerulonephritis, and we know that ANCA GNs are negative on immunofluorescence. They're called post-immune presentic type of GNs. Okay, so like Dr. Adarsh told you about in terms of pathogenesis, what is happening in these kidneys is just when these anti-neutrophilic cytoplasmic antibodies bind to the neutrophils and they are in the circulation, they go into the glomerular capillaries, and all that neutrophilic granules release all that their contents, which are very damaging to capillary walls. Okay, So there is no real deposition of immune complexes that happens there. That's it. Okay, any other questions? So your next will be a case study at 4 o'clock, I think. So you've got a good break in the middle. Any other questions? Okay, so I think we can close the session. Anjana, आप उसका देख लेना attendance का.
Okay,
4
ma'am.
o'clock.